Hi, it's Dr. Centeno, and thanks for joining me today. We've got an interesting topic. As usual, we'll start with a specific topic. I'll give a short presentation, and then I'll go into questions either about that topic or about really any other topic you'd like to ask about. So today we're going to be focusing on that sensation that a lot of patients have that they've got a heavy head or they feel like they've got a bobblehead. Uh, and we'll focus on one of the causes of that and then talk a little bit about how to identify that on MRI because it's oftentimes not on MRI reports. So many times the patient's just going to have to look at their own images. And then talk a little bit about how to solve that issue or different ways where that issue can be addressed here. So I'm told that it's not coming in on the other side. Should be here. Let's just take a minute for trying to make sure that this is working on the other side. So if you can see me on the other side, just go ahead and type it in the comments so I can get some information on that. Let's see here. I'm going to close a few items here. See if that reduces any of our potential issues. Okay, great. I just want to make sure things were going well. Okay, so again, we'll be talking about what causes a heavy head and why that happens. And what are some things you might be able to do about it? How do you make that diagnosis if you're in this situation where your doctor hasn't really told you what could be causing that? And we'll take it from there. So I'm going to share my screen and let's go from there here. Okay, so again, I'll start first with a short lecture about what does having a heavy head mean and why does this happen. Then you can answer, or then I'll answer questions about this or really any other topic. So heavy head, bobblehead, what's going on here? So a lot of patients report or symptoms that their head feels heavy or like they're one of those bobblehead dolls and they can feel their head kind of moving around too much, whereas before usually some event, it didn't do that. So what can cause these symptoms in a patient without any known other issues and someone who just has a chronic neck problem? So the first thing is we've got specialized muscles that hold your head up and can stabilize your head on your neck. Now, what's interesting is if you look at these muscles, you've got this big bowling ball of a head up here, and it's essentially being stabilized on a stick, or at least that's the thought process that's used. So you need very specific muscles. You can see muscles going this direction, muscles going that direction, going diagonally, sideways, up and down, etc. And if you just look at what these muscles do, you can pretty much figure out that their function is to stabilize that bowling ball on the stick. Now, there's also ligaments that can do the same, and we've talked a lot about ligaments here, craniocervical instability, what happens when those ligaments are damaged, what to do about that, non-surgical, surgical, injection-based, etc. And then I think those of you who have seen physical therapists, chiropractors, know that this 10 to 12 pound bowling ball that we have sitting on the top of that stick, if it moves forward, becomes heavier and moves forward, becomes heavier and moves forward, becomes heavier. Now, the problem is this right here, right? We all have these little phones. We all do this. And that's not helping stabilize that bowling ball on the stick. So posture definitely plays a role. And if this isn't something you've looked into and you have a heavy head situation, then this is the first place to start, right? This is really simple to try to work on these things. But today we're going to focus on the muscular components of this. How can those muscles that I pointed out just before, how can they have an impact on this whole thing? And what can you do to try to see if you've got that muscular type problem? So let's say you've gone ahead and fixed your posture and you know it's not that, and you've been tested for craniocervical instability and you know it's not that. Or even if you have craniocervical instability, is there also a muscular component, and how do you figure that out? So what's really interesting is that if you go up to most physicians and ask them, well, could I possibly have atrophy of my upper neck muscles? They're going to look at you like you got a third eye in the middle of your forehead, meaning that they just haven't kept up with this literature. But there's an amazing amount of literature out there that shows that atrophy of those upper neck muscles happens, and it's a common thing. It's a common thing in whiplash. It's a common thing in various neck conditions, etc. Now, what's really fun about this for me personally is this guy, James Elliott's probably the world's expert on this issue. He's at Northwestern. And Jim was one of our physical therapists back in the day. He went back and got a PhD, and now he's a researcher in this area as well as others. So that's fun for me personally, seeing Jim really lead the world in this kind of research right now. So this kind of thing is very, very common in traumatic neck injury and pretty much all CCI patients that we see. So this is someone's neck here, and this is at the C2, C3 level. And this is an axial MRI image here. So axial means it's a saw you in half view, and we're looking down. So this is the person's jaw. Obviously, that means this is towards the front. This is towards the back or posterior. And what we're looking at here is this compartment right here. And this compartment right here should be dark, but it's not, right? It should be this kind of dark here. That's a normal muscle. So on this type of MRI, this whole area that I just outlined in those ovals should be dark, but it's not. You're seeing a lot of white in here. And what does that white represent? That white represents muscular atrophy. And those are the muscles that we were just looking at that help to stabilize your head on your neck. So that's the kind of thing that we can see on MRI. Now, the problem is that if you read your radiology report, it's extremely unlikely that the reading radiologist has in fact done any of this or looked at any of this and placed it in his or her report. So you're kind of on your own here trying to figure some of this out. So how can you tell if you have this upper neck muscle atrophy? Well, one of the ways to tell if you've got this neck muscle atrophy is that you first want to make sure you've got the MRI sequence where the muscle is dark. That should be dark there. And the fat is bright. So if you look, for instance, on the right image, you can see that it's pointing to that little back fat or the fat that all of us have right behind our neck, and that's bright. And then if you look at the left image, you can see it's pointing to the muscle part, being dark. So that's the sequence that you want. And there are different kinds of MRI sequences. Some of them will not be able to show this. But if you look at this sequence, muscle dark, fat bright, and I'm not even going to tell you what it is because there's all sorts of different MRI sequences that can be included. That's the one you want to look at. Next, with the axial and sagittal shown, like I have here, scroll down to that C2-3 level as shown. So this is the C2-3 level, and that's the one you want to look for that fat atrophy, which occurs very, very deep in the spine there. So that's where you want to be looking. Next, scroll down to the next level, C3-4, C4-5, and you'll see that that same area now is darker, right? It's got much, much less muscle atrophy there, and that's more normal. Now, this particular patient actually has a little bit more muscle atrophy than they should at that C4-5 level, which is what is being shown on the right. That's that line going across. But you can see that there's a lot more muscle here than there was at C2-3. So now we're comparing these side by side. We can see the fat atrophy in the white there at the C2-3 image off on the left, and off on the right, we can see much, much less muscle atrophy and more dark in that area. So that's a more normal appearance on the right, even though there's some fat atrophy there, meaning the white, meaning it's not uniformly dark. But on the left, that's a lot of fat atrophy. And that would be how you would make a diagnosis of upper cervical atrophy to those muscles that stabilize the bowling ball on the stick. So if you've got that on your MRI, then that bobblehead or heavy head feeling could be caused by this atrophy that you're seeing on the MRI that's probably not on your MRI report. So the first thing you do is obviously get this diagnosed, and that may take a very experienced physician in this area who can read those MRIs for you, or you may need to do it yourself. And then you can obviously try to get a PT to strengthen those upper neck muscles. But if that fails, and it often does in people who have craniocervical instability, then you may need to get those upper neck joints injected or get injections to tighten those loose ligaments. Again, realizing that those kind of ligament injections in the high upper cervical spine are very, very specialized. And generally, I'm not talking about simple prolotherapy injections there. And then once that issue is fixed, you may need to go back and try to strengthen that area. But you also need to conceptualize that that's a long haul goal. And what I mean by that is that what we saw before were muscles that were about 80, 90% atrophied or more. So think for a second that if I put you in a cast for your whole leg, and 3 months later we take you out of the cast, and all of your leg muscles are 80% smaller or 90% smaller than they usually are, it's going to take you a year or more to get that muscle back. So that's the kind of thing we're talking about here. We're not talking about a couple of weeks of physical therapy to fix this. If they're that atrophied, getting them back is a long-term goal. So that's what I have for today. And I will get rid of all that and stop my share. And then we will go on to answering some questions here. Carol, I will have my second PICL later this week. I have a retroflex odontoid and pannus and did have a very difficult prolonged recovery after the first. In view of this anatomy, is there any way in which you would modify the injections for the next PICL? Let's see. Very prolonged recovery to the first, use anatomy. Not sure. That would really depend specifically on what it is we're doing here. and what's going on. I don't know that a retroflexed odontone and pannus makes a difference, other than it generally means that we may need to come in from above the atlas to avoid getting into the bursa, which is part of that pannus. Robin, hi, Dr. C, positive update. My C1 atlas bone is holding since January. Recent x-rays done. My 2 posterior treatments 3 months apart got me here. Sure, Robin. That's wonderful to hear. It's been advanced by Harry Winston. When I was first injured, my head felt like it was incredibly heavy, like 10 times its normal weight. That was my very first symptom, and all the brain fog, dizziness, etc. came after that. Is that typical with CCI? Pretty typical with CCI for all the reasons that we just discussed here. Bonnie, can stem cell therapy heal nerve damage throughout the body? Would that be an IV? Nerve damage throughout the body. Bonnie, I'd have to know more about what it is you're talking about. Nerve damage throughout the body isn't a diagnosis, so I would need to know what it is you're talking about. As far as IV stem cells are concerned, those end up in the lungs. There's a pulmonary first pass effect, so delivering stem cells IV wouldn't be the way to get them anyplace other than the lungs. So we need to know a lot more there before I could comment on that. Kesley, can CCI cause mild cerebral hypoxia? I would need to know a lot more about what's going on with that one to answer that question. Regenexx, mid advanced by Charlene. Can sleep apnea cause headaches and high blood pressure? Sleep apnea usually doesn't cause headaches. Now, craniocervical instability patients tend to have a lot more sleep apnea, and that can cause headaches. So there may be another association there or something else. High blood pressure is not necessarily caused by sleep apnea, but sleep apnea is a vicious cycle, right? When you don't sleep well, you get blood sugar instability. That causes you to eat more. You get metabolic, you gain weight, have high triglycerides and high blood pressure. So sleep apnea can, in a roundabout way, cause headaches and high blood pressure. But as you see there, there's other causes of headaches, and there's other causes of high blood pressure specifically linked to sleep apnea, which would be metabolic syndrome. Bonnie, do you use pluripotent stem cells? Let's see, mesenchymal stem cells would be pluripotent. I think what you're maybe talking about is totipotent, not quite sure. But yes, we use bone marrow concentrate, which contains stem cells. And the goal of bone marrow concentrate would be to use those stem cells to help areas heal. Robin, PPP is the best regenexx products. It's undersold, in my honest opinion. Yeah, PPP can work well, Robin, for very specific things. Pia, my son has in his CBCT an indication of rotational displacement of 8 millimeters to the right, 10 millimeters to the left. These measurements may not be equivalent to overhang since they're rotational rather than lateral. Do you happen to know how to interpret this measurement severity? Pia, I don't. We would use overhang. I've never seen any standard information reported on CBCT, meaning that in order for those measurements to have meaning, we'd have to know how many people who have no problems are walking around out there with those same numbers. And that's a specific study that has to be done separately in order to make sure that we can use those numbers clinically. So we have that for DMX. We know how many people are walking around out there with X amount of overhang, but I don't have that same information for CBCT rotation. I don't believe that research has been done yet. Jamie, where my hat, my head feels even more imbalanced. Is this normal? Yeah, that can be normal just because it can put obviously additional weight on some very weak muscles up there. And it looks like a bunch of people didn't see this lecture. So guys, I think I'm just going to do it again real quick here. I apologize, but hopefully we can get this done. But I apologize that you didn't see it. And I'm going to do it in such a way this time where I can continue to see what you guys are discussing here. We'll see if that works. Okay, here. Okay, so what does having a heavy head mean? Why does this happen? We'll go quickly through this stuff. I'm assuming you can see everything here. So a lot of patients feel like they've got a heavy head or a bobblehead. Obviously, what we're going to talk about here is those problems in context of neck pain. And they're very specialized muscles that hold up and stabilize your head on your neck. And those muscles, as you can see, go lots of different directions. We've got muscles that go straight up and down. We've got muscles that go diagonally. We've got muscles that go sideways. And all of that is to hold up the bowling ball, on the stick here. We've got ligaments that do the same thing. And as you all probably know, posture can do the same thing. When your head goes forward, it can dramatically increase the weight of your head. So dealing with that postural component is always a big part of what it is we're talking about here. Obviously, that's the easy thing to correct. And obviously, some of this other stuff would be after that. Now, we're going to focus right now on muscular components of CCJ instability. So surprisingly, this stuff has been published. It's all over the medical literature. There's 3 studies right here, all done by Jim Elliott, on the concept that atrophy as seen on MRI of the upper neck muscles is a problem associated with lots of neck problems. So this is a very common traumatic neck injury. So this is the front here. This is an MRI. This is the back here of the MRI. This is an axial view looking from straight down. And you can see the muscles, the deep muscles in here. And these deep muscles in here have white in them. And that white is fat atrophy. So that's what we're talking about. The problem is that this stuff generally isn't put onto an MRI report. And so how can you tell if you have this upper neck muscle atrophy? You can tell that with this sequence where the muscle is dark and the fat is bright. So you got to find that sequence first. So this is one of the neck muscles. It's dark. This is the fat behind the neck. It's bright. Then you move the slice to C2-3, and you see if in this area there's more bright than dark, and that would be fat atrophy. Then you can scroll down from that C2-3 level to more like C4-5 or so, C3-4. And while this person's has a little bit of fat atrophy in here, there's a lot more dark than light. And that's going to be a more normal appearance, although this one's not completely normal. So if you compare those side by side, you can see the fat atrophy over here. Here you see more muscle than fat, meaning fat's bright, muscle's dark. And that's how you would diagnose upper cervical fat atrophy. So if you've got that on your MRI, this could be a cause of that bobblehead feeling or your heavy head feeling. So the first thing is get it diagnosed. And regrettably, unless you were the real expert on this stuff, you may need to do that yourself. Obviously, you can try physical therapy to see if that works. If that doesn't work, you may need upper cervical facet injections or very specific injections to tighten those loose ligaments. And then once that's fixed, you can go back and get it strengthened again. But that's a long-term thing. I mean, it's not going to be a quick fix. So hopefully you saw those slides there. Let me get out of that. Let's see here. Okay, so hopefully you saw those. We'll go back to questions now. Liam, is there a way to test if head pain is from C0 or C1, C2 facet joints? Can this be done during the same appointment for PRP or PICL? Sure, yeah. The best way to do that, Liam, number one, easiest way is an exam. It can be a little more than that as well. We can block those joints with a numbing injection. And that numbing injection can either take your pain away when we put it at C0, C1, for example, under X-ray guidance with DSA and contrast, or it won't. So that's called a diagnostic block. Blake, Dr. Merkel showed the atrophy of my right side neck. I can feel it too, plus torn supraspinous nuchal. Sure, Blake, happy to try to help. Do you ever offer platelet cells for the PICL procedure or inject platelet cells? Platelets aren't cells, but we certainly put platelet-rich plasma in with the bone marrow concentrate. We generally don't do a platelet-based or a PRP-based PICL. We only offer a bone marrow concentrate procedure for that. Bonnie, I have nerve damage in my fingers and toes from frostbite. Yeah, Bonnie, I haven't seen this kind of stuff work for that before, but then again, haven't really tried to treat many frostbite treatment victims. That might be more just injecting PRP into those areas to see if we can get some nerve regrowth, but don't know if that works or doesn't. Anya, hi, Dr. Centeno. Can problems with capsular facet ligaments lead to facet joint instability, or is it caused by other spinal ligaments? Worth injecting the capsular ligaments to treat facet instability, should other ligaments be injected? Anya, generally other ligaments outside of facet capsular ligaments, the facet capsules are pretty weak in everybody. I'll give you an example of how weak they are, especially on the medial side. So we use the fact that they're almost always incompetent in anyone over 35 and the lower cervical spine to inject into the facet joint, and then that leaks epidural. So facet capsular ligaments are not real strong and don't provide a lot of the stability. The stability is generally provided by other ligaments. Pia, can you tell more about the process coming to the clinic, especially if it's not yet clear which treatment's needed? What does it look like in terms of consult time? What a stem cell treatment looks like? What a PRP treatment looks like in terms of process? Sure, Pia. So generally what happens is the patient would fly in the day before, if they're from out of town, obviously. They would come in for a full hour evaluation with myself and my assistant, Carla. We'll then, at that point, decide what needs to be done. Now, realize that the patient may have gotten a DMX here the day before, or they're coming in with something already. We've already, at that point, had a telemedicine visit. So we know pretty much what it is we're doing. We've got some idea, or at least, and then we go ahead and do a hands-on physical exam. We figure out from looking at the imaging from that, et cetera, where that person is going to head as far as treatment is concerned. And then patient would either do a bone marrow aspiration or a blood draw after that. Then they would come back in the afternoon, get treated, whatever that is. Usually that involves anesthesia. So the person is then discharged to the PACU. And that means that they'll be recovering from anesthesia from anywhere from 30 to 90 minutes, usually on average about 60 minutes. And then they'll be released from there to go back. So that's generally how that goes. Jamie, can CCI cause a change in CSF pressure? That's certainly possible. Jamie, just be a little careful there, because I see a lot of those diagnoses made on either on MRI findings or on just a spinal tap from the low back. And the only way to diagnose increased CSF pressure in the head is to float a catheter up there and measure it. And I find that less than 1% of the patients that claim to have elevated intracranial pressure have actually had that test done. So just be a little careful. We don't know that until you get that kind of test done. And those kind of tests aren't easy to get. Manuela, how important is an anti-inflammatory diet after PICL? I think the big focus there, Manuela, is trying to clean up dietary sins of America. And what I mean by that is that a normal diet, not a normal American diet, but a normal healthy diet, includes eating not much sugar, not much white bread, not much flour, not much pasta. All of those things are very, very occasional foods that someone who's trying to have a healthy diet consumes. It includes a lot of fruits, vegetables, etc. So, for instance, I'll give you a great example. Went to a restaurant yesterday. There's avocado hummus with the pita bread things. Didn't get the pita bread. You shouldn't get the pita bread. That was subbed out for vegetables. So that's a healthy diet. So that's the kind of diet we're trying to promote after a PICL or any other of these procedures. So what I would consider a normal diet, meaning a normal healthy diet, is not what a lot of Americans consume. So that's no soda pop, that's no sugary drinks. That includes orange juice, that includes cranberry juice, that includes all of that stuff. All of that is subbed out for water, et cetera, et cetera. So just to let you know that that's what we're talking about, and that's what we're trying to promote by talking about an anti-inflammatory diet. Pia, how do teenagers usually tolerate the injections? Well, the first thing to understand, Pia, is we won't inject anyone who hasn't gotten to skeletal maturity yet for a PICL. So skeletal maturity means that usually that person is at least 14, 15 years old, and sometimes older. Sometimes people don't get to skeletal maturity until they're 15, 16, 17, or 18, depending on that person. So we always want to make sure that you understand that as of yet, we haven't treated anyone who hasn't gotten to skeletal maturity, and there's no plans to add those patients at this point. Michelle, can you imagine a ballistic chiropractic maneuver or traction to neck damaging certain nerves that could cause shoulder or damage shoulder function? You know, Michelle, I think it all depends on the person, right? If you had very, very little room for the nerves that go to the shoulder, C5, C6, etc., and someone did a high velocity manipulation beyond what should be done, especially long lever, kind of cracking the head, sure, that could happen. And you all are 3 months out for first PICL and haven't started walking or laser exercise yet. I do move around the house, but not more than that. Should I push myself to walk more? How important is it? Manuela, I think you want to push yourself to just do what it is you feel you can do. What I mean by that is you got to thread that needle between not having a fear of movement and motion and also not pushing yourself over the ledge because you're not ready for it yet. So for instance, if walking around the house more, 20% more, doesn't push you over that, then great. Stick there for a week or so and see how that goes. If that's fine, then try 20% more or 10% more. That's the kind of thing that you should really be doing. So don't let fear of that hold you back, but at the same time, you also have to know your body. Oleg, Dr. C wanted to clarify my question regarding getting worse from injection therapies from last stream. Was specifically asking about CCI PICL injections. Plus, I think I heard similar cases with Prolo plus PRP. It's always a hot topic online, including it must be Centeno-Schultz. Loads of people reporting, reading about others. Some share own experience, reporting more instability or new symptoms. Others TCOC related symptoms outside initial recovery period. I think that cut you off here, Oleg. Yeah, I think my answer, Oleg, would be the same. And that is when it comes to people who are reporting prolonged increased symptoms after PICL that never went away, that's a pretty tiny number of patients, much, much smaller than the number that would report new or life-changing symptoms after something like a surgery. When it comes to a significant increase in symptoms that last for months, we certainly have that patient population, but those are the same patients that would get a similar response if they had an aggressive massage, or they happened to be in a car where they hit a big bump, etc. Meaning I would put those patients in the fragile egg category. So they're in that same category for pretty much everything. And the goal is to look at what's going on for those patients sort of 3 to 6 months later and make the decision of how they're going to proceed. Are they going to go on with a second procedure, or are they just too much of a fragile egg to treat? And we certainly see those patients. And then there's that other art, if you will, of trying to look at people and decide in which camp they are before the procedure. And I've been doing a lot more of that work. So for instance, we saw a guy from Europe, not last week, but the week before, and he had uncontrolled pain. Pain was 8 to 9 out of 10, depending on the day. He had tried all sorts of medications. Nothing was helping. No one was helping him in Europe to try to figure this out. And so we were basically, we made the decision, listen, we're not going to treat a lot in you because we have the concern that you're going to be that patient. We're only going to do a small amount of ligaments, and then we'll make some decisions about how to go from there. So hopefully that answers your questions. But I think what you're happening to see is outliers who are screaming loud, and not the entire group of patients who are sort of minding their own business, going about what it is they're doing. Because I look at all the information from all of these patients, and so I've got a pretty good idea of what's going on with the general patient population. HRH, what do the new ligaments look like after PICL at 6 to 12 weeks and 4 months? HRA, no way to image those ligaments accurately directly. I think what you may be asking is whether or not there's more stability on C1, C2 overhang. I think we just talked about that maybe 2-3 weeks ago. So I would go back to that particular Facebook Live, because I showed images and we went through all of that stuff. Paul, how long-term of a fix is this? Based on what we're seeing, it seems to be a good long-term fix, but that only goes, my experience with this procedure would only go back to approximately 5 years, maybe at this point. So what it looks like at 10 or 20, I can't tell you. Great. Sorry about the first thing, but at least we got those slides in there. Michelle, why does this atrophy happen in CCJ? Yeah, it's a good question, Michelle. I don't think anyone knows that for sure. A couple theories would be that when the upper neck joints get injured and these muscles start to act, it ends up increasing that pain. So the body shuts the muscles down. I think that's probably the leading theory. The other theory could just be exhaustion, meaning that because of upper cervical ligament instability, the muscles just can't handle it. And it's a little bit like, taking someone that's never run before and entering them in the Boston Marathon, and they have to run a marathon every single day for a month. You'd have people who would be young enough and fit enough to not crash and burn, but they'd be few and far between. Most people would crash and burn and get injured and never really make it to the end of the month if they were required all of a sudden, without any training, to run 26 miles every day for 30 days straight. So that's the exhaustion theory. Jeanette, do you see a correlation with sleep apnea? Yeah, we see it all the time. It says here, my sleep doc says I have a narrow airway. This causes forward head posture. Well, more the other way. Forward head posture causes a narrowing in the airway. In addition, we also see the same issues happening up top. So meaning that when things move around too much, that causes a narrow airway. And I think we have a Facebook Live on that particular topic that comes from, it was probably put out about 3-4 weeks ago. So you may want to go back and look at that one, because that one goes directly over this specific topic of how craniocervical instability in particular could narrow the airway. Michelle, why do you not use just PRP for PICL? Michelle, simply because our goal is to do as few of those PICL approaches as possible, given that that's a higher risk procedure than coming from the back, meaning that coming from the back and injecting anything from ligaments to facet joints there is a super duper, a common enough thing to have tens of thousands of cases to say this is the approximate risk with each one of those procedures. When it comes to the PICL coming from the front, we're only about 850 of those, so far less experience. So if we're going to come from the front and get into those ligaments directly, we're going to put our best foot forward with what it is we're injecting, and that's always bone marrow concentrate for ligament healing, better than PRP. Brian, my third BMA at your Cayman facility. My first one in 2016 yielded a strong cell count, but each subsequent BMA in 2019, 2022 produced radically fewer cells than the one before. Does science have an answer to what could cause this? Could it be that the MSCs are migrating to the inflamed subchondral bone? No, Brian, we really don't know that the stem cell count is different. That's just the nucleated cell count. Now, we did that study in patients. I think I may have even talked about it during one of these Facebook Lives, but I'm not 100% sure. But we did that study looking at the total nucleated cell count. And that study, I think, has now been accepted for publication. So it should be out here pretty soon. But what it basically showed was that as long as there was approximately 8 months in between each one of those draws, and we weren't dealing with an older woman, in general, there was no drop off in the number of stem cells or total nucleated cells that we took out. Now, so you may be seeing other effects, but at least in large number of patients, when we look at that, we don't see that drop off happening. So that could be related to different techniques, not quite sure. Could be related to other things that are happening with aging. But realize that that's a total nucleated cell count and not a stem cell count. So it could be that the stem cells really stayed the same. Anya, thank you. So during facet injections, the facet capsule ligaments aren't injected, only the facet cartilage. Intra-articular inside the joint, which would include everything inside the joint. That's the inside of the facet capsule. That's the actual, there's cartilage in there. Obviously, there are other structures in there. But as far as injecting the facet capsules as a major way to stabilize things, I think you're mishearing what people claim to be injecting, meaning that in order to inject a facet capsule, we'd have to put a needle in there and then make sure that we could see under X-ray guidance that the capsule was being injected, usually with contrast. You could probably do a little bit of it, but you wouldn't see the facet capsules all that well using ultrasound guidance. But I think what you're hearing from someone is that they are injecting, quote, the facet capsules and not the facet joint. And what you're really hearing there is, I don't have the expertise to know how to inject the facet joint. Hence, I'll claim I'm injecting the facet capsule. But all they're really doing is kind of putting the needle somewhere in the vicinity of the facet joint. So pretty sure that's what you're asking about, and that's what you're hearing. But realize what you're hearing is a little bit of a scam. At the end of the day, in order to inject those facet capsules, that's a pretty big deal because they're extremely flimsy and small, and you're not going to see it under ultrasound. You could theoretically see them under X-ray guidance with contrast, and there may be a reason to do that in selected patients, but for the most part, there generally isn't. John, I'm in on the low inflammation diet post-procedure. Yeah, John, I live in Boulder, Colorado, so we have a different diet here than everywhere else. I go traveling and I'm like, I can't believe what they're eating. Manuela, why would a throat drainage happen? I don't have allergies. It happens only on laying on my back, similar to postnasal drip that started after my injury. Manuela, I have to know a lot more information than that. about what causes throat drainage in your particular case, so I don't know. I think I got that one already. Jeanette, are you able to check if an upright MRI is clear enough before the actual Zoom consult? The quality of the upright MRI. Yeah, Jeanette, that's something you can do usually with Carla, but I'm not sure what you mean by clear enough, meaning that, again, a good thing to discuss here is DMX would be the most likely to show instability if it's present. Then the next likely thing would be an upright MRI with movement. And then the next likely thing would be a static MRI without movement, or a prone MRI. And those are all just likelihoods that will see instability if it's there. You may be asking whether or not it shows CCI before an actual Zoom consult, and probably not. That's something we'll be looking at in the Zoom consult. But if you want to up the odds of finding CCI if it's present, then you'd want to get a DMX for sure before the Zoom consult. Just follow-up question regarding teenagers and how they tolerate. If they don't grow any longer, how do they mentally tolerate the injections? I don't understand what you're asking. There may be a language barrier in that one. I don't understand what the question means, so maybe rephrase it. Anya, do degenerative injections help with artery compression? I lose eyesight and hearing when I look up and my blood pressure falls, or should be solved by AO nuke or surgery before doing injections. I think what you're talking about, Anya, is usually, if we're talking about CCI here, the cause of instability is causing that. So the goal is to reduce the instability. And that could either be done through a regenerative injection technique like PICL or surgery. The downside with surgery is that surgery fuses things so they don't move at all. The goal with a regenerative approach is to allow them to continue to move like they were built to move, but not move as much. So I think what you're talking about is instability causing that. So the goal is to get rid of the instability. Instability means things move around too much. Peter, what is PPP used for? Yeah, PPP stands for platelet poor plasma. And we tend to use it more for muscle issues when we're dealing with myocytes or the skeletal muscle rather than the muscle tendons. Michelle, sorry, but my question didn't come across completely correctly. What about a neck traction injury causing shoulder dysfunction? Is it possible to get a neck traction injury? So that would be a brachial plexus, an upper brachial plexus traction injury caused by chiropractic. I haven't seen that as much out there, so not sure I can comment on that one just because it's not part of my day-to-day clinical experience of things that I've seen happen with chiropractic care. Deanna, if there's now a variety of new sensations of something pushing in the throat from the CCI. I don't have any context for that one. Dina, maybe you had left something else up there that I missed, but I don't have any context for what that one means. So maybe ask that one again. Liam, regarding symptoms like palinposia, sensitivity to light, visual snow, and constant tinnitus, is it possible to have symptoms like this due to nerve irritation, or is it likely high ICP? How do I find out? Liam, when it comes to those types of symptoms, and let's kind of break things down a little bit. So high intracranial pressure. Again, the only way to diagnose high intracranial pressure up here would be to do a catheter test. And that's where someone floats a catheter from your low back up into your brain and measures the pressure. Can't really get it from the eyes. Certainly can't get it from a lumbar puncture. Then we get into the idea of high intracranial pressure. And usually in this context, and there's other contexts as well, what we're talking about there is a compressed internal jugular vein. And when it comes to compressed internal jugular veins, of those, tinnitus is one that's commonly associated with that issue. when we look at studies of patients who have had known compression of the internal jugular vein causing their symptoms, then it was decompressed and the symptoms went away. So tinnitus is the one out there that is most likely to be related to IJV. Melissa, should a woman with CCI wait until after she is done having children to have PICL? I need a maybe a PICL, but I'm planning to have more children. And with pregnancy, the joints loosen because of relaxin that will cancel out the benefits of the procedure. Now, relaxin, Melissa, just operates for the last trimester and usually the very end of the last trimester. So once you take away the relaxin, the ligaments go back to normal. It's just in that very last portion of the last trimester, relaxin is released. So just so everyone understands, what Melissa is talking about is there's a hormone released at the very end of pregnancy, and that hormone causes the ligaments to relax. And that one of the things, the functions of that is to allow the big baby's head to get through the vaginal canal by allowing the SI joints and symphysis pubis to open up a little bit. But as soon as you take that away, unless there's been some damage by the baby's head, those ligaments return back to normal. So I'm not quite sure I would do that unless everything was pretty mild, right? If everything's pretty mild and it's not a big functional problem, then absolutely wait until all the pregnancies are done. More because there's just too many moving parts. There's a lot going on. You got to pick up a baby, etc. If we're talking about more severe issues and more severe problems, then the concern would be baking those problems into permanent. What I mean by that is that we certainly see patients who have had this going on for so long and it's been so bad and so undiagnosed that their problems get what I call baked into permanent. And that means that the damage is done and there's no way to reverse that nerve damage. So it is what it is. We can get them more stable. We can improve some things, but we can't improve all of the symptoms. Paul, asking about how long it takes to get rid of a bobblehead. Generally, Paul, if the muscles are as atrophied as the ones I showed, I'd give it a year or more of working on that kind of stuff. Just because, again, if you just think about the visual of me putting your leg in a cast for 6 months and then breaking open the cast, and we've all probably had that experience where the doctor takes off the cast and you're like, oh my God, what happened to my muscles? Where'd they go? And so if those muscles were 80, 90% atrophied or smaller than they were built or before they went into the cast, as you might imagine, that's not a 1 month thing. It's not a 2 month thing. It's not even a 3 or 6 month thing. That's about a year to get that muscle mass back. So same thing here. Melissa, also would it benefit someone who has an alar and transverse ligament damage to have some lower PRP done before going straight at the PICL? Would that be a waste of money? Don't really see that is helpful in most patients unless there's something going on down there causing a lot of symptoms. And then that's something that certainly could be done for sure to treat those lower cervical problems. So we certainly see people who have lower cervical issues and have upper cervical issues. And in that particular patient, yeah, treating lower cervical spine might help a portion of their symptoms for sure. Connor, sometimes I'll be asleep and then in my sleep, I'll shoot up super fast and it worries me because my neck for heavy head. I feel my instability is back to front sliding. Connor, something else to look at there, and you can certainly get done within the NHS, is to get a sleep study, because a lot of times that a sleep study will diagnose if you've got sleep apnea and especially are getting hypoxic at night. So one of the biggest causes of bolting like that or waking up suddenly is that the airway is blocked. And when the airway is blocked, that's causing hypoxia, meaning your blood oxygen level is going low. And at some point it gets so low that your body says, alarm, alarm, and wakes you up. So that's another possible cause here. Dina, if there are sensations of something pressing into the back of the throat because of CCI, What could that be? Sometimes it feels like a fist behind the throat, or sometimes a point. Sometimes it feels like being strangled. What kind of MRI could show the issue clearly? Yeah, Dina, that can happen in CCI patients. It can also happen in anyone who's had an injury to the anterior longitudinal ligament after something like a crash. So that can be swelling because, surprisingly, there's not a big distance between the back of the throat and those neck bones. In fact, in most patients, in some areas, it's only a centimeter thick. So a quarter to a third of an inch thick in some people. So if there's a problem in the front of the neck there, some people are going to feel it like that. I've even had patients who report problems swallowing, and they've got to get swallowing studies, et cetera, et cetera. I wish Kirker in London would change his mind about not CCI, but upper cervical facets. He's only hope. Yeah, Connor, nothing I can do there. He just didn't feel like he had enough accumulated experience in that particular area of upper cervical facet joints. I think in addition, many CCI patients have a lot of different problems and issues, and they're certainly much more hands-on than other patients. So that could be another thing going on there. I don't know, but you and me both. Anya, can I ask, when you're talking about fragile patients who decide not to treat extensively, do you mean people with severe or widespread pain, or people with a lot of morbidities? As an example, I'm mainly bedbound right now because of how severe my spinal pain is. Oh yeah, Anya, that would definitely put you in that category. We're not going to treat a lot on the first outing. And that's just based on experience. And it wouldn't even matter if you were a CCI patient. We'd do the same if you were a patient with just routine severe back pain who was bedbound with constant 8 out of 10 pain, meaning that you're in that centrally sensitized category where, at least for the first time, less is more. How do teenagers deal with the procedure itself? I don't think any different than anyone else in their same categories. So pretty similar. But again, make sure that you understand that we only treat skeletally mature teenagers. So if we're talking about a 12-year-old, that's a no-go for this, for the PICL procedure. Oleg, let's see here. So I think I did that, but I'll give it to you again. I've done this on a couple different of these right now. So as far as the percentage that get, so we got to break these into a couple of categories. So the first would be the percentage of people that get new symptoms that last more than 6 months. And that's a very low number. I'm going to say 1%. Then number two would be the percentage that get a prolonged flare-up lasting 3 to 6 months. And I'm going to say that's maybe 10%. Then we get into those that have an abnormally long flare-up, but not quite 3 months. So let's say we're talking about anywhere from 0 to 3 months, but that go beyond a few weeks. And that's probably 1 in 3 as far as the flare-up is concerned. And then the rest of the patients would be within that 3-week mark, and that's now most of the people. And in that area, I would say we probably have half of those people who don't even know that they got a procedure. And what I mean by that is they may be a little sore for a couple of days, but they're not really noticing much of anything. And then the other half of those people who are from a couple days to a couple weeks. So hopefully that answers your questions. Main issues people experience, mostly just a flare-up of their index symptoms. Why does this happen? It's mostly due to central sensitization, or that fragile egg that we talked about, right? Meaning that if you're the kind of person who's bedbound and you've got an 8 or 9 out of 10 pain that's uncontrolled, you are the kind of person that's going to be in these categories of prolonged flare-ups. If you're the kind of person who can't get a massage because it'll flare you up for 3 weeks, then you're in this category. If you're the kind of person who can't ride in a car at all, because if that car hits a small bump, you could be flared up for 3 months, then you're in this category. So very, very important to realize who's in this category and what we're talking about there. Because all of that is probably related to central sensitization. And what central sensitization means is that the central nervous system is out of control. And the amount of pain that the patient experiences is magnified above the tissue damage that the patient's experiencing. So those are all patients who are at high risk for prolonged flare-ups. Anya, how is artery compression connected to CCI? Anya, we've done a couple different things on that. Let me see here if I can pull out a new window, because I think we've gone over this one before on Facebook Live, but it's also on the blog, and I can search that easier. So if we look at, let me pull it up for you guys. So this would be, let me share this here, the blog to look at. So this is the blog you want to look at, talks about how C1 and C2 are close to, especially the transverse process of C1 to the internal jugular vein, the internal carotid artery is here. It also talks about how other nerves are here, vagus nerve, glossopharyngeal, etc., and how all of that can get impacted. So that would be the one to look at and read. I've actually had a sleep study. It came up fine, but I've had this shooting awake apnea issue for a while, and the sleep clinic has discharged me now. So Connor, there's a couple different things there. One would be what kind of sleep study. So there's two main kinds now. One being a little thing that you wear at home. The other being you go in there and they actually observe you sleeping. So if you could just put in the comments so I know what kind you had done. Lindsay, how many PRPs should be tried for disc bulges and annular tears? Would adding stem cells to my second PRP possibly help more? Generally only one, although every once in a while we've done two, but no more than that. So if you didn't have results with a high dose PRP or bone marrow concentrate injection, then you'd be looking at hypoxic culture expanded mesenchymal stem cells as the next step. But obviously we need to know more about what you had done. If you're severely misaligned, does this atrophy the muscles even in like 2 months? Are you more at risk for damage if you have an accident, jar the neck? Certainly the muscles help protect things. And so that would put you at a little bit more risk for injury, all things being equal. And muscles can atrophy fairly quick. And some of the Elliott studies I was showing and some others, we're talking about within the first 6 to 12 weeks, they're seeing atrophy. Pia, nuchal ligament, to what extent do you believe it will regain its strength after it has been compromised from an incision? Would there be any regenerative treatment that could help this healing along? Pia, I'd have to know more about what incision you're talking about. If you're talking about a skull-base decompression, usually those ligaments are destroyed there, as are the muscles in that area that stabilize the head and neck, the very ones we were looking at before. So I need to know a little bit more about what it is you're talking about and what the incision was. Anya, thank you. So a person with constant severe pain can respond somehow differently to injections. Absolutely, quite differently. Do you mean recovery would be harder or they'd be different? Exactly. My main symptoms are orthopedic, severe pain and facets, but not severe arthritis, not neurological. What can be different in my response to treatment? Yeah, Anya, if you've got pain levels in the 8, 9, and 10 range, you're going to more likely than not respond very differently than someone who has pain levels in the 3, 4, 5, and 6 range. And that's because that 8 to 10 range is observed for nerve type pain. And so that means that there's some nerve problems there. Now, that's all things being equal. That doesn't mean that everyone in that category responds differently. It just means a generalization that most people in that category respond differently. Oleg, I get flare-ups of symptoms for prolonged computer driving, car working, physically massage, but it's usually more while I'm doing the activity and perhaps next sleep during the day. Is that sensitive or good bounce back? Yeah, Oleg, listen, if you've got things like, heck, I did something wrong. I know I shouldn't have done it like that. And I get a couple days of pain, day 2 or 3, depending on how severe it was, but then I'm kind of back to my baseline. You're probably not in that category. What I'm talking about is someone who gets a massage and they're out for 3 weeks, or someone who gets a bump in the car and they've got 3, 4, 5, 6 months of payback for that bump in the car. So not really someone who has a small blips in how things go, but who lives who's got very high pain levels or symptom levels and lives in an extremely narrow band. And if they get out of that band in any way, then there's major flare-ups that can happen for prolonged periods of time. Deanna, hi there. Thank you for the work in this field. Does overhang at C1, C2, odontoid lateral side bend correlate with alar ligament rupture? Deanna, rupture is probably a bad word, meaning that we don't see many alar ligament ruptures when we look on MRI. We tend to see alar ligaments that get partially torn or have their internal fibers torn and they allow too much motion, but not snap back like a rubber band, which is what the word rupture implies. Then you go on to say, for example, 5 millimeters overhang. Do you confirm if an alar ligament is ruptured prior to the PICL procedure? So Deanna, of all the alar ligaments I've looked at, I don't know that I've ever seen a ruptured alar ligament at all. And I've probably looked at least a couple hundred on MRIs of that specific area of the upper cervical spine. So no real reason to confirm if it's ruptured. As far as 5 millimeters of overhang, just to let you know, we would put mild overhang in the 2 to 4 range. We would then go on to the moderate overhang of 4 to 7, 7 to 8, and then the severe overhang of 8 plus. So that would be in the moderate category from overhang, or as overhang is concerned. Now, that doesn't mean it necessarily fits with someone's symptoms. We've seen people with less overhang and more symptoms, and vice versa. A lot of overhang and they're not all that symptomatic. Oleg, what percentage of CCI patients see improvement after the procedure? Pretty much all the rest just see no change. Yeah, Oleg, I think right now, in general, taking all comers, we're seeing about 7 in 10 report positive improvements. That's consistent with the research I just reviewed. I think I talked about early last week that our team, again, looked at about once a year. Our team is going through this data. But that could be different for different categories of patients. So, for instance, I believe that the traumatic folks that we're getting relatively early within that first year are knocking the ball out of the park versus getting someone who's had this problem for 2 decades and it's never been diagnosed. And it's now so severe that they can't get out of bed. So different things there. But in general, that's what it looks like. Mark, how can you determine if there's an interosseous SI ligament, the sacrotuberous ligament, sacrospinous ligaments are injured and need to be treated? Can this be done with a physical exam, ultrasound exam? Interosseous SI joint ligament is very hard to see. I don't know that we see it very often on SI joint MRIs. So most people would have them, but not something that's going to be easy to see on an MRI or CT scan or ultrasound, that kind of stuff. Anya, can I ask, what do you mean by people in the 8 to 10 out of 10 category respond differently? Do you mean they respond worse? Yeah, Anya, those patients are more likely to get flared by any kind of injection-based care. So it doesn't matter if it's this or if it's a low back epidural or injecting the SI joint ligaments, etc. Now, that just means that if we take 100 people in that category, 50 or 60 are likely to have a very substantial flare-up by doing anything like this. Then we get into the other 40 and how do they go? Well, maybe half of those have some flare-up, but still exaggerated relative to the rest of the population, and the other 20 are more normal. So that's the best I can tell you. But yes, you would be more likely to have a more prolonged flare-up and to be in that category of people that either get new symptoms or those symptoms of flare-up last for an obnoxiously long time. So that is what that is, and that's part of central sensitization. We've known about that now for about a decade. It used to be called fibromyalgia prior to understanding central sensitization, and some doctors still call it that. Okay, we are at 2:11, and I think I'm also going to do a separate video. I will keep this one up because there's a lot of good information in this one, but we'll also post a separate video of those slides in case somebody missed that part of this presentation, because this does have some information in it about how to read an MRI and try to make your own diagnosis of upper cervical muscle atrophy. So I think it's an important one for patients to understand if you're really struggling to find a doctor who will read your MRI and look at those things. There's a couple more questions that just came in. Deanna, in terms of radiation exposure, I know we have to weigh the risk versus benefits. However, is it possible for us to work with you, have our workup for upper cervical facet injection or PICL based on existing imaging and MRI versus needing additional DMX pre-post? Yeah, Deanna, we don't usually do pre and post on a routine basis anymore. We did that very early on. But when it comes to the post, we would only do a post at this juncture if we're trying to figure out if that person objectively improved when there wasn't much subjective improvement after the first one. So what I mean by that is, let's say someone has their DMX, shows instability, or we've made that diagnosis through another imaging study, and then they get the procedure, but they don't notice a lot of subjective changes, meaning symptom changes, by the third or fourth month. So then we're repeating the DMX, but only in that case. And so that means that for the vast majority of patients, we never repeat the DMX unless there's some reason they want it repeated, or unless we have some reason to repeat it, like we've done 4 of these procedures and they've gotten substantially better, but they're still having issues. So the question then becomes, is there still instability to treat, or are we treating other things? So that's what it is we're doing with the DMXs. So there wouldn't be a need to repeat the DMX unless there's a specific amount or type of information we expect to get from that we can't otherwise get in another way. Lindsay, do you commonly hear patients complain of choking feeling or like having something stuck in their throats? Yeah, Lindsay, I think we've talked about that up here. Although my DMX shows CCI, my pain symptoms and MRI match more with disc bulges and annular tears. So that's what we treated. But I also have that heavy head feeling, intermittent feeling of choking or throat pressure. Just wondering if those symptoms can be from a disc-related issue or caused by CCI. Yes. So patients with neck injuries, not only CCI, frequently report that sensation of choking or having problems swallowing. So I would definitely talk to Dr. Schultz about that. And there may be some things specifically on your MRI that can cause that. So for instance, sometimes we'll see a bone spur coming out of the front of the neck that's pushing right at that spot that patients are feeling that pain in the back of the throat. So definitely talk to him about that. If a patient is receiving TMJ treatment, maxillary advancement and palate expansion, is it okay to receive regenerative treatment simultaneously? No, I mean, those are pretty aggressive, invasive therapies. So I'd kind of stick with doing those more aggressive things before you go back and do less invasive things, because that's kind of skipping over a bunch of steps to get a much more invasive, higher risk procedure to solve it than regenerative medicine. And I'd want to let that play its course well before we got involved, for that reason, meaning that complication rates with things like that would be much, much higher, because that's a much more aggressive surgical procedure than what we're talking about. Oleg, info about me, HUDS, upper back issues, 19 years ago, late teens, functional, progressed slowly, January got significantly worse, but still functional. Obviously, this person being more. Yeah. So listen, Oleg, always happy to answer questions. My goal is to answer them as honestly as possible. I'll tell you a quick story, and then we'll kind of start wrapping this one up, since it's 2:16 on my end. So I think we've been going for an hour and 16 minutes. But listen, my job is to be as honest with you guys as I possibly can about what the risks are of this procedure, the risks of any procedure we perform, or just about trying to answer your questions. And a little story was that my niece has CCI related to EDS. I've actually got two nieces in that category, so it must be something genetic on our family side. And I had asked her to go see a neurosurgeon just to get that perspective before we proceeded with any type of care, just because I wanted her to make sure that she understood you can do A, what's behind door number A, or what's behind door number B, or door B. And she did. And interestingly enough, the neurosurgeon put me on speakerphone when he was describing to her the risks of upper cervical fusion. And I have to say, I was really blown away, because you see me here talking about percentages of patients that get this, percentage of patients that get that, what's the likelihood that this will work, et cetera, et cetera. In neurosurgery world, with this surgeon, not all surgeons, I know surgeons who are much, much better than this and who explain it better than this, because I've talked to patients of theirs. But in this particular neurosurgeon's world, basically the way it was described was that this was always going to work, and it had very little to almost no risks. And it was not even going to result in much loss of range of motion when he was going to fuse C1C2, which is where 50% of all the range of motion comes from. So off the bat, she was going to lose 50% of her neck rotation just from fusing C1C2. And the reason I tell that story is I was appalled by listening to that. It was a sugar-coated version of the risks of upper cervical fusion, which are dramatically more than anything we're talking about here today, including dramatically more for permanent increased symptoms, life-changing complications, et cetera, et cetera. So my goal here is to make sure that you guys know this. It's one of the reasons why I am all over social media once or twice a week trying to answer your questions, because I want to make sure that you're educated about what it is you're getting involved with, whether you go with what's behind door A or what's behind door B. Doesn't really make a hill of beans difference to me, as long as you understand what those risks are. So that's my job here, is to try to make sure that you understand what those risks are, and that you fully understand that there is no such thing as a medical procedure that doesn't carry risk. Doesn't exist. So anyway, that's a little story I want to tell. I'm going to take one more question, and then I got to start shutting it down, because we're getting into an hour and 20 minutes here. Jeanette, sorry, Dr. C. Should have explained that TMJ treatment is not surgical. It's a conservative alternative, taking a couple of years oral devices. Yeah, Jeanette, same thing. Finish that, and then we'll talk. Deanna, Okay, guys, thanks so much for your time today. I really appreciate all of your time. Again, an educated patient is always a better patient. And I just want to make sure that I'm available for you as we go through this journey together to try to figure out what's best for you. And that means making myself available to answer questions so that you know which end is up, you know which end, what's right, what's left, what's down, so that you can figure this out and pick the best course of treatment for yourself. So have a great week. I think I'll be here on Friday. And thanks so much for watching. And I will see you, I think, this Friday. Thank you.